We're pleased to be bringing you this IHSPR policy round, which is focused on improving care for people with multiple chronic health conditions. The learning objectives for this session are outlined here. Basically, we want to understand the key features of multimorbidity as a health system problem, learn evidence-based features of a comprehensive approach to address multimorbidity, along with key considerations to ensure effective implementation of related health services. We want to explore the early stages of Ontario's Community Health Links program to improve care coordination for patients with complex chronic disease. And finally, to learn and share challenges and best practices with other provinces and territories. To quickly outline how today's session will unfold, I will introduce the speakers, and we'll hear from both the researchers and the policymakers involved in this topic with a description of the research results and the policy implications. Towards the end of the webinar, we'll be taking questions through the chat mechanism, and we'll facilitate some continued dialogue and connections. So I'll introduce now the first speaker, Dr. Michael Hilmer. He's the Director of the Planning Research and Analysis Branch within the Ministry of Health and Long-Term Care. And he's been part of the Ontario Public Service since 2007. He's been involved with many exciting projects during this tenure at the ministry, including developing the Chronic Disease Prevention and Management Strategy, the first trilateral First Nations Health Senior Officials Committee, and creating guidelines for multiple sclerosis care. Michael holds a PhD in clinical epidemiology and a master's in pharmacology from the University of Toronto. Our second speaker is Mike Wilson. He's the Assistant Director with the McMaster Health Forum, an Assistant Professor in the Department of Clinical Epidemiology and Biostatistics, and a member of the Center of Health Economics and Policy Analysis. He's also an investigator with the Program in Policy Decision-Making at McMaster University. Mike's research is focused on supporting the use of research evidence in health systems with a specific interest in community-based organizations and health system managers and policymakers. He is also interested in research related to the politics of healthcare systems and the social determinants of health for people living with HIV and AIDS. Mike helped lead the development of health systems evidence, which is a key source of research evidence for the development of evidence briefs at the McMaster Health Forum. So I'm now going to pass the control over to Dr. Michael Hilmer, our first presenter. And Michael, please take it away.
Wonderful. Thank you, Jennifer. I want to thank also CIHR and the Institute for hosting this session. I think that this is such a huge, important topic to focus on, both from a research perspective to better understand the complexity and needs of this population and interventions that work, but then also the policy perspective and how to put those findings into practice to improve care. So I'd also like to thank Mike Wilson and John Lavis at McMaster for their great work on developing the evidence base, which Mike will present after I'm done with the background and context section. I think this is a great tag team. So I'm going to get started. So the issue of chronic disease it has a broad level of awareness of the patterns. Many people have chronic disease. The burden is unquestionable. If you look at the work of University of Washington and the global burden of disease, it's quite clear that the majority of ill health in Canada is directly attributable to chronic disease. The costs of the healthcare system are overwhelmingly related to chronic disease. So this is these issues are the ones that everybody knows about. So it's not. Today's session isn't about awareness of chronic disease. This is a classic slide that shows the prevalence and won't surprise anybody. But where I wanted to focus some of my comments and have you come away with a much better understanding is the overlap of these conditions and the impact on the costs and utilization related to this overlap. And of course, the overlapping of the chronic conditions comes from the fact that they all share a common etiology in terms of the common risk factors. And on the left of this slide, you'll see a series of common risk factors, and these are the modifiable risk factors. So things like misuse of alcohol and physical inactivity and an unhealthy diet, all lead to the genesis of chronic disease. So on the right-hand side are just two classes of chronic disease in particular, and I only show two because if you show more, it quickly becomes very complicated to show visually. But you can see that many of these risk factors are directly attributable to the genesis of a particular chronic disease. And then even to make things more complicated, diabetes itself is a major risk factor for the development of cardiovascular disease. So you have these multiple causal pathways acting, and that says nothing about the age of the individual or the genetic risk, because as individuals age, they become more at risk of chronic disease. If you look at the prevalence rates stratified by age, for the most part, they start to skyrocket quite quickly. The other interesting thing to note is it's not age in itself that is a particular burden on cost escalation, and I think this is shown pretty conclusively in a recent CIHI report where they look at the different drivers of what is increasing costs, and age alone is really only responsible for a very small percentage. However, as an individual has more and more chronic disease, their care becomes more complex, their burden becomes higher, and the care becomes costlier because of the intensity required to care for these people appropriately. So now we have the idea of multiple overlapping conditions, and really we have a handful of really thoughtful scientists and clinicians who are leading the charge in developing the evidence base for looking at these overlapping conditions and the impact. People like Cynthia Boyd at the United States, who is a real proponent of creating more rational guidelines for people with multiple chronic diseases. Martin Fortin in Quebec. We have Moira Stewart at Western University, and Walter Woches here in Ontario. They all bring different skill sets to bear on this problem, but they are building up the evidence base around what this population looks like and what we can do to better care for them. And they were all involved in some way or another in this work. So these sets of overlapping circles, represent Ontario. The large gray circle is the overall population. Then you start thinking about those with select chronic conditions, and these are the big contributors: arthritis, asthma, cancer, COPD, and so on. And roughly a third of the population has at least one. And then you think about hypertension and heart disease and diabetes alone, and you see all the overlaps there. And again, it's hard to show more because it becomes very chaotic to look at. So now you think about the same set of categories: patterns, burden, and cost. And they're all significant, but the story changes a little bit. I'm going to, in the next few slides, use evidence that has been generated by Walter Woches and his Health System Performance Research Network. He's actually one of the groups that we fund in Ontario through our Health System Research Fund, and he has been an enormously productive researcher and has a number of graduate students and affiliated researchers. So he is creating an enormous amount of capacity to look at this issue. So what's interesting, and I'll show slides to this effect, is that disease prevalence between 2003 and 2009 has increased a little bit, but the prevalence of multimorbidity has increased significantly. We know that multiple chronic conditions are really associated with a whole range of poor outcomes, and Martin Fortin showed this very conclusively in the mid-2000s. And when you start looking at the costs, and again, Walter's group has shown this, you're starting to look at exponential increases in costs, and the ramifications of that for the healthcare system are just profound. So this is the slide that I was alluding to. You look at the blue bar, which is the prevalence of one condition, and really you just are talking about a 1% increase, which is negligible in the grand scheme of things. But you look at the proportion of people with 2 or more conditions and just how quickly it's rising, and that speaks to the increase in risk that people face because of their risk factor profile and the aging of the population. This is a very telling slide. So I apologize, somebody is just trying to dial in here, so I will continue on. If one thinks about creating disease-based strategies for populations with multimorbidity, that approach is challenging because of the data presented in this slide and the next. So you look at the people with one condition, these are, and what's in the percentages in the bracket, for example, the asthma is 29%, and on the right is the proportion of people in an Ontario-based cohort who are represented by the top 5 clusters. So when you think of people with one condition, those top 5 conditions are asthma, arthritis, hypertension, depression, and cancer. So those people collectively form 91% of a chronic, a broad-based Ontario chronic disease cohort. When you start thinking about people with 2 conditions, so listed are the top 5 there, hypertension and arthritis, depression and arthritis, and so on, they represent 52% of the total people in that cohort. When you start thinking about people with 5 conditions, the top 5 are listed, but they only represent 6%. So the diversity of presentation of individuals with 3, 4, 5 plus conditions is so vast that it is essentially impossible to think about a disease-based strategy for everybody. So you start to need to think about what is the holistic approach a health system needs to take to care for these individuals effectively. So this slide shows it in a different way. So thinking again of the people with 5 or more chronic conditions in Ontario, there are about 350,000 of them, of these individuals. There are 243 distinct clusters of 5 conditions that only account for 50%, roughly 175,000 people. When you think of the next 50%, it is literally thousands more distinct clusters. So this is impactful right off the bat, because clearly you're not going to come up with something that addresses each individual cluster. It really does need to be a system-based approach. This speaks to the cost escalation. So I think you can see, just quickly looking at this, that it is an exponential curve for these are people for less than 65 years of age. It really doesn't change the pattern doesn't change, the absolute cost increases do for people over 65, but again, an exponential relationship between number of chronic conditions and cost. So I'm just going to spend the last minute or so of my first component of this presentation, before I hand it over to Mike to talk about the evidence base, to talk a little bit about some of the structures and investments that Ontario has made to try and start addressing this very omnipresent issue. So we have initiatives like the Ontario Diabetes Strategy, which is a disease-based strategy, but really was the first out of the gate that attempted to implement the elements of the chronic disease prevention and management framework that was originally designed by Ed Wagner. We have key infrastructure in agencies like Health Quality Ontario, Public Health Ontario, and Cancer Care Ontario. A huge investment in multidisciplinary primary care over the last 10 years. We have service coordination through the community care access centers, and they become critical when you think of these complex, vulnerable, multi-comorbid populations. And finally, the analytics and performance management capability of organizations like ISIS. And it's the data that resides at ISIS that people like Walter use to generate those very compelling slides that I just showed you. Very quickly, this is the Ontario CDPM framework, adapted from the Wagner model and from the BC model. I won't dwell on the diabetes strategy. You can look at this slide at your leisure. But I will say that we, in the research branch here in Ontario, oversee the Health System Research Fund, and this is the fund that provides Walter with the research dollars to do his work, also Moira Stewart, and a whole host of other individuals. And really we see it as the research and development function of the Ontario healthcare system, and we're able to set up calls for research and bring the policy relevant findings to our colleagues. It makes us very different than any other province because the research funding function in Ontario resides within the government, which makes us both the funder and the end user. So I won't dwell on the individual streams of the research fund because I want to be able to hand it over to Mike and hear about the evidence brief that he and his colleagues developed at McMaster.
Great, thank you, Michael. So similar to Michael, I just first like to start off by thanking CIHR for pulling this together and giving us the opportunity to present, and also to Michael for being such a great partner on this project. I think it's been a great experience to be able to work with the ministry on this really important topic. So what I'm going to do is pick up from where Michael left off and talk about the process that we went through at the forum in consultation and partnership with Michael and others to develop an issue brief and convene a stakeholder dialogue at the McMaster Health Forum about designing integrated approaches to support people with multimorbidity in Ontario. So just as a very quick overview, I want to give you a sense of our steering committee, just because they're such an integral part of this project. And then the bulk of the presentation is broken into key findings related to the issue brief that we pulled together, which I'll explain, and then the key findings from the stakeholder dialogue, which are two key documents that we have posted on our website. So I think Amanda and Hawa from CIHR are going to be posting the links to those documents, but if you can't find them otherwise, then all of the documents related to this dialogue are on the McMaster Health Forum webpage, mcmasterhealthforum.org, and then you just go to the products page and everything is there for you. So in terms of our steering committee, this is our approach to integrated knowledge translation, where we work from start to finish with a small group of individuals, both policymakers and researchers and others with some helpful expertise to really guide the project from start to finish. So we had members from the Ontario Ministry of Health and Long-Term Care, the Ottawa Hospital Research Institute, University of Toronto, and McMaster, so all were very integral in this project. So the general role of the committee was to engage with us in pre-dialogue teleconferences that helped us to make the event plan, develop the terms of reference for the issue brief. So this was essentially our map for how to pull together the document, how to do the searches, and they provided us with feedback about our synthesis and work related to the brief throughout all the stages of it, and then also to identify people to invite to the dialogue itself. and then we followed up with them afterwards about the dialogue summary that we wrote as well. So in terms of the issue brief, so one of the two key products that came out of this project, our overall goal is to try and mobilize the available research evidence about the general context for the question, and then also the problem, three elements of a potentially comprehensive approach for addressing the problem, which sometimes we call policy options, and then key implementation considerations, meaning that if we're going to take up one or more of these elements, how might we actually be able to operationalize them? And then a key feature of this is that we draw on systematic reviews, primarily and specifically related to the elements of the potentially comprehensive approach for addressing the problem, but then also things like local data and studies, many of which that Michael just spoke about in clarifying what the problem is. And the goal of the brief is to be an input to discussion and not an end to itself. So we design the issue brief so that it's pre-circulated before the stakeholder dialogue, it's taken as read, and then everyone is coming in with having read it and engages in these deliberations based on the available research evidence. So with respect to the issue brief, I'm just going to run through the three main sections very quickly, and I'm not going to spend very much time on the problem because I think Michael already did a fantastic job on explaining almost all of the key pieces of the problem section within the brief. So the main things that we highlighted in the brief were, as Michael noted, the growing prevalence of multimorbidity coupled with the fact that prevalence grows steadily with age. So I think that came home very strongly in some of the graphs that Michael just presented. And then the other piece about the impact of multimorbidity on healthcare utilization. So just to note that while, yes, so spending certainly increases for the people with most complex conditions and people living with 3 or more conditions specifically, but a number of people on our steering committee also noted that it's really important to highlight that higher healthcare utilization and costs might be entirely appropriate for this group as compared to the rest of the population, given the complexity of the conditions that they're living with, and addressing them in order to help them reach their goals and improve their health. But what the important point is that that higher healthcare utilization really points to where greater coordination and integration of services might actually have a significant impact on improving the efficiency with which care is provided. So I view it as more of an indicator of where might we be able to better use those costs to do things more efficiently and potentially reduce costs in the long run as well. So then just some other key points, which I think Michael also very helpfully covered. For the most part, the first is just the complexity involved with living with and treating multimorbidity. So there's a number of health risks, numerous and varied and all interrelated. So it's not a dominant disease model like the comorbidity model, but it's these overlapping circles where there's not necessarily one dominant disease. And then the approaches to self-management and treatment are just made so difficult and complex given the need to treat so many, or a number of different conditions at the same time, sometimes with competing outcomes and competing treatment approaches. And then at the system level, it's not always supportive of integrated care. So as we often know, there's fragmentation of programs and treatment strategies, both across settings and across diseases. This often then places a heavy burden on the patients as well as their family, friends, and caregivers who are supporting them along the way. And that remuneration models aren't always aligned with the types of care that are needed by people living with multimorbidity, which are often longer sessions with their physicians, working with many different team members in a primary care group, and et cetera. And then also a lack of effective local governance, particularly at the primary care level, that's supportive of integrated care. So these are kind of the highlights that we go into more depth in the brief. So I'm just trying to hit home the key messages that we made in the brief that's available for you. So building on the problem, we crafted in consultation with our steering committee as well as with a number of key informant interviews with people both in Ontario and across the country, 3 elements. And the first one was focused on models of care. So it was focused on supporting primary care, community care, and other providers to adapt and implement models of care for patients with multimorbidity that improve their experience, improve health, and keep per capita costs manageable. So within this, we had a few sub-elements that could be part of this broader approach to models of care. The first is identifying unique contexts in which care is required. Next, identifying promising models of coordinated or integrated care. Third, supporting local adaptation and implementation of care models. And lastly, developing performance measurement frameworks to identify high-performing models. So before I launch into the research evidence, just an overall note about each of the three elements that we included in the brief is that we really didn't find very much research evidence at all about these elements. And so we focused on identifying systematic reviews, which is usually our approach for developing evidence and issue briefs at the forum. But as many of you probably know, having been involved in this area, is that the availability of the evidence is a bit thin on that level still. So the point was to try and mobilize what we could and then have it as a point of discussion during the deliberations as well. So for this element, we found a few systematic reviews, but only two that were focused specifically on people with multimorbidity. So they're both recent reviews. One's by Smith et al. And is published in the Cochrane Library, and the other is by De Bruin et al., which is published in Health Policy. So both of these reviews indicated that there's mixed and inconclusive evidence regarding the use of comprehensive care models in patient-oriented interventions. So it doesn't necessarily mean that they don't work. It just could mean that we don't have the evaluative models right, or that we aren't looking at the right outcomes. But they did say that targeted care delivery interventions, so things like integrated treatment programs coordinated by care managers, were more effective than those with a broader focus, so case management in general or changes in care delivery in general. So the more targeted the interventions, the more effective they were. And then the other key message that came out of these reviews is that complex and multifaceted pharmaceutical care was effective at reducing inappropriate medication use in adverse drug events, which is a very significant issue among people with 3 or more conditions because they're managing lots of different medications. So that's an important finding to note. With the second element, the focus here was on guidelines. So Walter was talking about some of the, Cynthia Boyd's group, who's really focused on trying to think through how do we develop guidelines. So in this element, we focused on activities to ensure that guidelines meet the needs of patients with multimorbidity, but also activities that assist primary care, community care, and other providers in identifying and using those guidelines. So here, we really didn't find very much with respect to guidelines. We had conducted a colleague and I, Francois-Pierre Gauvin, who works with us at the McMaster Health Forum, we developed a knowledge synthesis earlier in the year in 2013 with one of the sections focused on guidelines for people with multimorbidity specifically. And so we didn't find any guidelines that were specifically focused on people with multimorbidity, despite looking through many sources and contacting a lot of people. But what we did find was a lot of literature talking about this. And in that knowledge synthesis, we make a list of 15 recommendations that we are able to pull out from all of that literature. And I've listed the most frequently cited 6 here. So those included making sure that there's information on the most common multimorbidity disease clusters, along with the main chronic condition. Making sure that any guidelines that are produced take a patient-centered approach to the development of them. Cross-referencing guidelines with each other, in particular, those that where recommendations are synergistic or contradictory, or when patterns of multimorbidity are common. And also, it was noted in many, many publications that the need to use patient-friendly language to make them most approachable to people, and to consider the feasibility of the recommendations in those guidelines for people who have to actually manage the care that are recommended by them. And then lastly was more of a methodological piece, which is about including older adults and patients with comorbid conditions in randomized controlled trials, and include the results of those studies and guidelines. So the idea is that we can't produce guidelines that are going to be relevant to people with multimorbidity if we're not including the populations of interest in the studies that would inform the development of those guidelines later. So the third element was about enabling self-management, and here we had two sub-elements which were focused on ensuring self-management resources were sensitive to patient needs, and second, providing supports to self-management in primary care and related settings. So again, there's lots and lots of literature about self-management out there, but for this brief, we really tried to focus on any that were focused either specifically on multimorbidity or those that were focused on people with multiple complex chronic health conditions. So we only found a very small number of reviews that fit that criteria. And the benefits that we found were related to patient education and family interventions that helped patients use self-management resources in general, and information and communication technology, home-based support, and a range of interventions that were aimed at supporting appropriate medicine use by consumers. And then lastly in the brief, sorry, I'm just noticing a few things come up on the chat. Are people not able to hear me?
This is Hala. From my Montreal office, I can hear you fine,
Okay.
Mike, and I can see that a few other participants are able to hear as well.
Okay. Okay, so I'll keep going. So hopefully it gets addressed for the one person that flagged it. So for the implementation considerations, we flagged both infrastructure and investment implementation considerations. So infrastructure being, to leverage existing infrastructure such as health links in Ontario and other models of care for self-management. And then for investments, so looking at existing networks with expertise in research synthesis, guideline development, and knowledge translation. So maybe groups like KT Canada or other existing networks where there's a hub of research going on with this type of stuff. And then we also, in our implementation considerations, try to identify various windows of opportunity for the dialogue participants to mull over as they're reading the dialogue and engaging in the deliberations. So we had 4. The first was the difficult fiscal situation, which could be an impetus to do things differently. Primary care in general being the focus of investment in many jurisdictions over the last decade. And overall increased awareness of multimorbidity among guideline producers. There's now lots of people thinking through this. I know that in conversations with the Guidelines International Network that they're very interested in trying to pursue this type of work, among others. And patients are increasingly keen to participate in managing their conditions. So these are all potential windows of opportunities that we've flagged. We'll just move on to the stakeholder dialogue, which is where a lot more of the key insights from stakeholder participants came out. So the overall goal of dialogues is to allow us, as I said, to bring that research evidence from the brief together with the views, experiences, and knowledge of those who are involved in or affected or might be affected by or making decisions in this given area. So we follow 2 key features. First, that we follow Chatham House rules in our dialogue. So participants are free to use the information following the dialogue, but they can attribute it to a specific person, which means that people are able to speak very frankly during the day, and it's essentially an off-the-record session. And that we don't force consensus. So sometimes consensus does emerge, but we don't try and force it because we find that if we do, then it can stagnate the discussions. In terms of the participants, we try and bring in participants who are able to bring unique views and experiences to bear on the challenge and who are well poised to champion initiatives in their different constituencies following the dialogue. So for this one, we had 20 participants. 3 of which were policymakers. We had 9 managers, and many of those were involved with the health links in Ontario, so bringing a lot of that on-the-ground knowledge of what we're doing currently in Ontario with respect to health links. We also had 3 providers and 5 researchers. So on one level, these distinctions are artificial because some people wear multiple hats, so there's people that could fit in 2 or more of these categories as well. So in terms of the deliberations about the problem with respect to the brief, everyone largely agreed that yes, there's a lack of integrated approaches, but many questioned for whom is there a lack of integrated approaches. So some of the participants noted that are we really targeting people with or at risk of multimorbidity, which was largely the focus of the brief, or are we looking at more vulnerable people like low-income people with multimorbidity, or just in general complex and vulnerable patients? Where integrated approaches could be very beneficial or high needs patients is what some people noted, and high needs being in relation to both healthcare and the full spectrum of the social determinants of health. So not just healthcare, but many other things. And then others spoke to the notion that the full trajectory or journey for a patient, so not just those living with multimorbidity, isn't always the focus of care. And many viewed this as a missed opportunity for making sure that the 45% of people who are at risk of becoming complex or high needs patients don't tip over to the 1 or 5%. So prevention being a really key missed opportunity, and providing person-centered care that emphasizes a holistic approach. So those were two things that were viewed as potential missed opportunities as a result of not looking at the patient journey. We also talked about the lack of clarity about the goal of addressing the problem. So some wondered whether it's a goal in itself. So in other words, to improve the care for and the health of those with multimorbidity, or others viewed it more broadly. So is addressing this a means to an end of strengthening primary care and to make it better equipped to address all patients, or is it a means to the end for improving the patient journey for people with multimorbidity and other individuals? So some talked about how, if we get it right for this most complex group, then it's going to have many other spillover effects and benefits to many other people that would benefit from the system being strengthened. In terms of the elements and the deliberations about them, when we discussed models of care, most of the dialogue participants focused on the need to continue supporting bottom-up and person-centered approaches and flexible models, and specifically to identify and prioritize needs and goals that are important to patients. So it's shifting that view of outcomes to patient goals, and that came out very strongly. And also to harness our resources to develop customized packages of resources and to work for the full spectrum of primary care models. And then building on that, need to focus on how to support the scaling up of successful approaches when we find them, both within practices, so horizontal integration, and other parts of the system, so vertical integration. And then related also is building capacity among health professionals to work in these types of new models. With respect to guidelines, the patient-centered approach again came out very strongly, and also the need to mobilize clinical resources that help people achieve these goals. So it could be resources to address goals explicitly, or address complementary goals like reducing polypharmacy, so having multiple medications, and guidelines that better address issues for people with multimorbidity. In terms of self-management, similar themes came out. So any tools and resources were emphasized that they need to be developed through partnerships between providers and citizen groups to make sure that we have efficient and good communication between them. Move beyond the usual suspects of education to also include things like skills building and direct support for behavior change. Enabling better system navigation, which is one thing that some people have been investigating increasingly, and reaching more people through social media and technology. So using these new types of outreach models to get people engaged and to help them, and to connect people who are facing similar challenges. In terms of implementation, collaboration was a really big theme that came out, and this was emphasized both as collaboration within teams, but then also across silos, but with an emphasis on making sure that each of those silos still brings unique value to the overall goal. Engaging patients, families, and caregivers, designing funding approaches that are supportive of models for care for people with multimorbidity, so using morbidity adjustments for blended capitation, for instance, and fee-for-service, and making better use of technology again, so electronic medical records or computerized clinical decision support mechanisms. All our dialogues wrap up with next steps, so for people to let us know what they think could be some potential next steps. So lots of folks talked about the need to stay the course, to continue to support bottom-up and person-centered approaches to developing models of care and to working across silos, and that included identifying people at risk, including those that are hard to reach, monitoring and evaluation, exploring how to scale up successful approaches, building capacity, supporting the development of evidence-based guidance, so especially about processes for care and not just prescriptive recommendations, embracing innovative and collaborative approaches for self-management, And also, lastly, articulating a research agenda to address terminology issues and the many unanswered questions in this domain. So I'm actually now doing a project building on this, that builds on this a little bit, and specifically doing a gap analysis of all the available synthesized research evidence related to high needs users, and trying to identify where the biggest gaps are in the research evidence to help a priority setting process in this area. So that's it in terms of the key findings from the dialogue. So these are just my acknowledgments to both my co-authors and our funders, which was CIHR, the Ontario Ministry, and McMaster's LaBarge Optimal Aging Initiative. And then anything you need is available on our website at the Health Forum. So I think back over to Michael.
Thanks, Mike. That was terrific. And yeah, so it's Jennifer Campbell here, and we're just turning things back to Michael Hilmer. He's going to talk now about the Community Health Links Initiative. And I'll just ask everyone to keep your questions. We'll have an opportunity shortly at the end for you to put into the chat box your questions. So thanks very much, Mike. And now over to you, Michael.
Wonderful. Thank you. These slides come from our Transformation Secretariat, which is a body inside the Ontario Ministry of Health led by our Helen Angus, who is actually our interim deputy minister right now, and her responsibility is implementing the pillars of our minister's action plan for healthcare. And this slide here is really those pillars. It's reduce the historical growth in spending, try to figure out better ways to deal with the people who aren't as healthy as they could be, that risk factor profile, get a better handle on the few people with complex needs, and have a better system to respond to the needs of seniors. So this is a slide that the Transformation Secretariat and our deputy used just to illustrate the challenge in terms of the demographic bulge that will come and the cost that's associated with it. So I'm going to move now into this province's specific policy response to the, not just the idea of multimorbidity, but although that is a defining characteristic of the individuals who will need this type of integrated care, but so community health links are an organic effort of local providers in a geographic region, a primary care site, a hospital, a community care access center, who will get together, identify those individuals who are most at need of coordinated care. These are individuals who are seeing a dozen different providers, having 20, 40, 60 different interactions with the healthcare system, dozens of medications, dozens of interactions with social service agencies. And we know that their access isn't always the best. We know that the cost could, because of the lack of efficiency, the cost could be lower, and really improving the quality is a key aim of this idea, and the means to do it is the integration. So really the health links are about trying to achieve the triple aim for the most complex users of the healthcare system. And so what's interesting about the health links is that there are now almost 50 of them, and maybe going up to around 80 or 90 at steady state. And their initial focus is on, you heard Mike Wilson talk about the 1% and the 5%. Well, it's identifying those 1% of Ontarians who are using the system, every day, 2-3 times a week, and just need their care coordinated better. So their main focus is identifying these individuals, making sure that they have a coordinated care plan, and then really doing their best with their local resources to try and figure out a set of interventions that might work better for these individuals. And what's been fascinating about this effort is that it has been very organic, and a lot of variation in how these health links are being established is being witnessed right now. And so it's brought up an interesting tension from a policy perspective in the need to encourage local innovation and the bottom-up approach that Mike talked about versus identifying what is working really well and trying to standardize that. So we're really in the phase of innovation and bottom-up development, but also mindful that as those stories of success start to generate patterns, that we'll be able to hopefully transfer those successful approaches into more of a standardized approach for this population. So this slide really just talks about the principles around developing a patient-centered approach and the ideal success we hope to get from it, in that greater coordination of care, which is really about structure and process, but about leading to that better satisfaction with care, more efficient care, seamless care, and hopefully better outcomes from all of that as well. So this is a slide whose data that's in this graph also came from Walter Wojcik. So he did an analysis of everybody in this province and attributed costs to their care over the course of time. And this included hospitals, physician visits, drugs, all from the Ministry of Health's perspective as payer, and really did confirm what everybody intuitively knew, that this was a very skewed relationship. 1% of the patients consuming roughly a third of total health expenditures, 5% around 65%. And so that's why the Health Links, this new mechanism of delivering integrated care, was devised, in that we needed to get a handle both from a patient satisfaction and patient-centered approach and from a system approach on how to do it better. So the hope is that once there are 90 of these naturally occurring networks that have a whole range of providers around the table really focused on their 1%, is that most of that 1% is captured by the Health Links. And then the stories and patterns that emerge from those 90 around the 1%, well, then we can start applying those to the 5%. And because as Mike said, it's about prevention as well. You can't just focus on the problems that are presenting in front of you. There are real opportunities for prevention as well. So some of the early successes for HealthLink, then for the action plan overall, is really shown in this slide. Around the pillar of healthy Ontarians, our health promotion division has been working very hard to implement evidence-based practices around smoking cessation, and has seen a drop in smoking rates since 2003. They've launched the Healthy Kids Strategy, which is focused on reducing childhood obesity. They're focusing on limiting the use of tanning beds for minors. A whole range of other health system successes in terms of dropping ER use for primary care. The overwhelming majority of Ontarians now have access to a family doctor, and again, as I talked about, there are now 200 family health teams, and this is the multidisciplinary primary care approach, and 3 million Ontarians have access to those models of care. And the other big pillar is the right care at the right time at the right place, and the Health Links are really about getting the best possible care to these individuals who need it the most. So it's trying to figure out who they are, and not trying to figure out who everybody in the province is and their individual service needs. And this is, I think, a revelation in some ways, in that there are specific populations within the province who need very specific kinds of things, and the health links are about serving those with the high needs and the high interactions with the system, and creating, you know, a series of service buckets that are meeting their needs. And again, you can't meet the disease-specific aspects of their care because it's too complicated, but you can look at them from what do these people need to, you know, maintain their functional independence? What do they need to be able to avoid the use of the ER? And it's probably not going to be about developing those disease-specific strategies. So I think I will leave the rest of these slides for you to take a look at on your own, because I want to leave time for questions, and I know there are a lot of people online, but really I just want to hammer home the idea that the community health links are a made-in-Ontario solution that is based on evidence, and that we know a patient-centered care approach is the way to go. But the way in which we're doing it in Ontario has to reflect our structures and processes, and the health links have generated an enormous amount of excitement and energy in that I think providers wanted to be able to do a better job for these individuals, but weren't always able to because of the organizations they were in and their mandates. So the health links have given them a common purpose to channel their energy into what they get excited about coming to work every day to do, and that is providing the best possible health care to Ontarians who need it the most. So with that, I will hand it over to Jennifer to facilitate any Q&As that might come up.
Thank you, Michael. That was an excellent overview of that Health Links program. I'm sure some people on the line are more familiar with it than others, but we do have time now to have questions for the presenters. And so again, the way you would do this is to write your question into the chat box. If you could please direct it to all participants, then everyone will be able to view it. I will read the question, and the appropriate presenter will provide an answer. So please go ahead and start to formulate your questions. So I see one here. Given the high-cost users, 1% and 5% are likely determined based on the public spending, 60%. Would the researchers be able to determine the high-cost users, including the private spending, which is 40%?
How do you want to handle the questions, Jennifer? I mean, I think I have one answer. I guess I'll start. It's Michael Hilmer. Would they be able to? That would be really challenging. The reason Walter Bochis was able to do that kind of analysis is that the data that is at ISIS is linked with a unique encrypted identifier, so you could construct these longitudinal profiles of people through time, and that's what allowed him to do that graph with such precision. So, you know, there are two things. One, he wasn't able to attribute all $48 billion of the healthcare system, because there were a lot of unattributable costs around overhead and fixed costs that, you know, aren't person-specific. So he wasn't able to attribute that. And the private spending, unless you had some way of linking it to an individual or determining it on a small scale, I think in using that province-wide approach wouldn't be possible. It's a good question, though, because that spending is it's hard to say whether it would follow the same pattern or not.
So I can jump in here too as well, and I agree with what Michael said for sure. And also, in the brief we highlighted this issue a little bit, and one of the things we noted was about caregivers, both paid and or unpaid, so informal or unpaid caregivers in Canada. So the overall estimated value of informal caregivers in Canada is in the range of $25 billion. So that takes into account lots of things like labor force and lost wages and other related financial impacts. So a systematic review did find that those people who are intensive caregivers or primary caregivers were much, much less likely to be in the labor force as compared to non-caregivers. So that's one way that we can look at some of the additional expenses that go around this. So there's public expenditure in terms of the health system. There's some private expenditure in terms of maybe things like out-of-pocket costs for pharmaceuticals or for home care beyond what's covered publicly. Then there's also a lot of that largely difficult to document costs that are as a result of providing care, especially for these people who have complex conditions. So I'm not sure that's fully the answer you're looking for, but it might offer a little bit of additional insight.
Sorry about that there. Maybe I can go to another question that I've seen. So this question comes in from Caroline Wong, and it says, you discussed patient-centered approach. How have patients been engaged to be involved in any development of research or programs related to their care?
I think it's a great question, Caroline. I'm not sure if it's a specific question related to HealthLinks or more of a general one, so I'm going to take the liberty to answer it from a more general approach, and that this is I think the research field in general is starting to wake up to the value of involving patients in different aspects of the research process, and I can think of two sort of specific examples that are happening in Ontario and more broadly. Andreas Lapakis is an internist at St. Mike's, and he holds a Canada Research Chair in methods of patient engagement, and he's done some really interesting work around citizens panels and how to solicit input from patients in terms of setting priorities. And his perspective is that, when it comes to setting priorities for research, there is a rich set of information that can come from patients, and he did a very neat process with patients on dialysis. And so he used a structured process that the James Lind Alliance in the UK developed for gathering that input, and then really did come up with a very interesting set of priorities that had overlap with the traditional clinician researcher set priorities, but did have some differences. And so he's at the forefront of trying to do that, and some colleagues of Mike's at McMaster, Julia Abelson, are really looking on how to do this. And then a relatively new group led by Shalom Gluberman, just a few years old now, Patients Canada, is really starting to ensconce themselves in a bunch of different priorities. So they're advising HealthLinks on how to maximize their patient-centeredness. They're working with groups like Accreditation Canada and other national organizations who have a role to play in setting the accountabilities and performance management expectations of healthcare agents in the system. So I think it's a growing and emerging field that is happening. So great question. Thank you.
And I'll also jump into that as well. So thanks, Michael. One of the things I should have mentioned in my presentation is that one of the additional pieces of the project that we've since done in collaboration with the ministry is we convened a citizen panel at the McMaster Health Forum. So this is a new initiative that we've been engaged in, is around convening panels of citizens to discuss what the problem, options, and implementation stuff. So they get a citizen brief, which is kind of a lay version of the evidence or issue briefs that we write, and then they have a facilitated discussion. So we held one of those a couple months ago. The report emerging out of that panel is not yet ready, but it was led by, as Michael said, Julia Abelson has been very fundamental in helping us pull together this new program. So that's one way that at least we're trying to get feedback from citizens with respect both to the research agenda and also about the types of solutions that they think or difficulties that they're encountering within a system, and then feeding that back to researchers and policymakers to hear what people are thinking.
Thank you, both Michaels, for that response. And I just want to jump in quickly for everyone on the line just to let them know that in terms of citizen engagement and patient-centered care, the Institute of Health Services and Policy Research will be hosting a Café Scientifique on April 1st in Toronto. So I'm just going to share that link with everyone. And it's around consulting the public and citizens, caregivers, and patients around what the priorities should be moving forward in healthcare as we try to build a pan-Canadian vision and strategy for health services and policy research. So although the event will be held in Toronto, we will be live streaming it so people can take part online across the country. So thanks again for your comments around that. And I think we can move on to the next question there, Jen.
Okay, and the next one, I just wanted to pick up on the question a little further down about measuring change in patient experience. Do either of you want to comment on that at this point? So how do you plan on measuring change in experience?
No, I think that it's Michael Hilmer here. I think it's a fair question, and I saw one question in the queue there around the tension between quantifiable measures that are residing in admin data versus the experiences and viewpoints of individuals, which are not routinely captured necessarily. So and it's a good point, and measuring patient experience is something that all of the hospitals in Ontario do. They use a standard tool. It's typical measures of satisfaction, and I think on that front we're looking to some of our stakeholders and research community to step forward. Again, I'll point to Shalom Gluberman and Patients Canada and some of the work he's doing. The Change Foundation is working with some people in Cobourg and really trying to do deep dives with individuals. But I don't know that there's a state-of-the-art, and we're certainly open to different kinds of ideas. But there are survey tools, there are case study approaches, but that will probably be one of the next big evolutions, is trying to bring some rigor to the notion of measuring patient experience.
Okay, so another question from Paula. Health links are defined in their own populations of high users. How does this relate to the 600,000 plus high users that you indicated in one of your slides? So I think that's to Michael Hilmer. Michael, do you have a comment for that one?
Sorry, which?
So question of the health links are defining their own population of high users. How does this relate to the 600,000 plus high users that you've indicated in your slides? I think it was the very last slide.
Do you mind if I go back to that slide?
I think it's this one.
Oh, it's a good question. I mean, the target enrollment is for the 90. If you look at the sort of strict definition of the 1% of the Ontario population, you come up with with one particular number, but that's not necessarily the number that's going to get enrolled in all the health links, because each health link has to make a decision as to how they will find the people and how they will enroll the people. But as for that particular number, 648,000, I'd have to defer that to my colleagues who are implementing the health links. And if the individual who asked that question wants to get to me offline, I can make that connection for you if you have some very detailed questions about the process of how they're doing that, because I'm not sure I can answer it with the level of specificity that you might desire.
Okay, thanks, Michael. From Lori, what interventions do health links provide to the high users or to the high needs patients, and who are involved in the team?
Oh, I think that's a great question. So the main intervention right now that all the health links are trying to figure out how to do is develop that coordinated care plan. So they're identifying right now patients sort of in the hundreds of totals. And with those early entrants into the health links initiative, they're looking at their care needs, and that starts with a case conference process. I mean, everybody's going to do it a little different, but essentially you gather around a table the key providers of care for that individual, and it would typically involve a primary care physician and the associated allied professionals that are part of that team, perhaps somebody who's involved with the admission and discharge processes of the hospital, of the local hospital, the case coordinators from the local community care access center, some of the local social services agencies who are out there providing things like Meals on Wheels, or sometimes they, if you're thinking about different kinds of populations, you might have some of the agencies that are providing kids services, or maybe even the police or justice, because there's a realization that these health links planning tables have come to that the high users of the healthcare system, in some cases, are the high users of other kinds of services. And again, that's completely intuitive, but without the structured care coordination tool that goes through certain elements, here's what you need in terms of your social services, here's what you need in terms of your home care services, and here's what you need in terms of your medical services. And then trying to put that all in an integrated record. So a big part of the Health Links initiative is trying to figure out what is the electronic management of these integrated records look like, and what does a good care plan look like. So that's where the local innovation is coming to bear, because each link is trying to develop something that is useful for them, because as Mike so rightly pointed out, there isn't necessarily a lot of evidence to guide what is going to be an optimal approach. So we're going to rely on local innovation, look for the best patterns of success, and try to spread that at a pace that gets to all the health links. So the teams look different. It really depends on who is present in a local area and what kind of patients form the initial part of the pool that individual health link is focusing on. So you could, the 1%, it was interesting, Walter looked at that, excuse me, and found, there were some distinct subpopulations. So there are the individuals who were at the end of life, and their spending was high because of the intensity associated with hospitalization. There were individuals who had mental health and addictions diagnoses, and there were kids with who are medically complex, and then there were frail elderly. So really, depending on which subpopulation you're talking about, that will drive whether you need the constellation of services that are around the individual. So I guess I will just end by saying the health links are an enabling process by which those services that are so needed to deliver optimal outcomes for the individual are coordinated, they communicate, and that the handoffs between the service provider agencies are guided by a commonly accepted care plan.
Thanks, Michael. And I'll just remind everyone to please, when you're typing your questions, please do it in the chat box as opposed to the question and answer. That way everyone can see the question. Another question, this one from Leslie. Given the approaches to complexity of care will require teams and other innovative approaches, what steps are being pursued to align health professions' remuneration, in particular physicians? Has that been tackled, and how?
Yeah. It's Michael Hilmer here. I mean, it's an excellent question. I think over the past decade, the investments made in multidisciplinary primary care are a huge step forward in this regard. You know, identifying, that we need multidisciplinary care teams, and that we need rosters of patients who are attached to these teams with providers, on different kinds of salary models. That is not just strictly fee-for-service. So right now, the health links are really respecting the existing schemes of remuneration. Each health link, has been given some development resources, and a lot of this will go towards some of those development activities I talked about, around analytic activities to identify people, care plan development, some of the IT needs. But we're tapping into the pent-up desire of people to provide better organized care, and whether remuneration schemes will change or not is a good question. I'll point to the existence of health system funding reform, which has started to change the way in which hospitals are funded, so that dollars follow the patients in a better way rather than the standard global budget. And that's a notion that is going to be expanding. Less and less money will go towards global budget and more towards activity-based funding in what we call our quality-based procedures. And whether that keeps expanding is a good question. Ontario is new to the health system funding reform experience, and I think that funding has a role to play in this. But right now, the links are really bottom-up processes and being driven by passionate people.
And Lee has asked a question. Many complex health needs patients are unattached and homeless and utilize emergency rooms for their care. What role does HealthLinks have in addressing the care needs for these individuals?
Well, that's a great question too, and the specific approaches the links are taking to homeless individuals, I can't say for certain. Again, if you're interested in more information on that topic, I would ask that you get in touch with me, and I'd be happy to connect you. As you get more granular in your questions about the links, I'll be less able to answer them because it really is being led out of a different area. But I know they're keen to promote what's happening, and my colleagues would be happy to get back to you.
There's a question here about scale up. How do you scale up these kinds of things to larger geographical areas? This one from Stephanie.
Well, I think that's one of the key issues that the Transformation Secretariat are trying to enable. And like I know in Toronto Central LHIN here, there are links emerging, and if you have a dozen health links in the GTA, you've probably covered off most of those individuals, but what are the different approaches that are needed to ensure health links work in diverse, dense settings that don't necessarily have the history of intimate collaboration that a smaller site might have. I think a lot of that, our Transformation Secretariat colleagues are really looking for local leaders, and the notion of leadership can't be understated here. We are working with our colleagues at McMaster right now on really trying to figure out what are some of the elements of leadership that will enable the best kinds of success in the community care setting, and what can we do as a system to promote or to identify and promote those kinds of leaders. So those who've stepped forward as key leaders, people like Camille Orridge and Stacey Daub, to be honest, I think we're looking to them to be key champions in the field and tell us what's working, and we'll do our best to assist in the scale and transfer of those key lessons.
Terrific. We've got a question from Lisa about health links, and again, if this is too specific, Michael, we can have them get in touch with you. But do the health links initiatives still require the traditional model of having primary care physician only, or are there opportunities for nurse practitioners as well?
Well, that's the amazing thing about health links, is that they are about harnessing and connecting the local resources across a broad range. And what's been really heartening for me and my colleagues is seeing how quickly these health links have embraced a set of services that are much more reflective of the broader determinants of health. So there might be individuals around as part of the team who are real experts in the social assistance programs the province might have to offer. If there's a nurse practitioner clinic, there's no reason at all that they couldn't become involved. So this is really an all hands on deck, whatever you're willing to put into it kind of effort. I don't know the extent of the involvement of nurse practitioners, but this is really about identifying those people in need of care and developing that link-wide resource of what's available and how it can be translated into a basket of services for the different subpopulations of those who are identified.
Okay, lots of questions about health links. Someone's asked if you can describe them a little bit further and how they look in the community. Is it possible for you to do that, Michael?
How they look in the community, that's a good question.
Is it a place in the community?
So this is a key point, and I'm glad the question was raised. These are virtual networks. These are not, they don't have a storefront. So this is about a group of providers coming together and for the most part, they're not going to be in the same room. So there are lots of teleconferences, video conferences, and they're discussing, I think at this point, really in the development kind of stage, and in other cases, the health links that are more advanced, actually enrolling patients, about organizing care so that transitions are more seamless, moving from hospital back to primary care or back to the community, or making the transition from having home care services to not. So it's not like you can visit a health link. These are webs of providers that coalesce around patients who meet the criteria for entering a health link. So and again, if you want more specific examples of what they look like and their constellation, I highly recommend getting in touch with some of my colleagues. So Anna Greenberg is the director of the Transformation Secretariat, and it's her responsibility her responsibility is leading the rollout of these health links.
We have a question about how are you going to address care for the 700,000 patients in Ontario with myalgic encephalomyelitis, fibromyalgia, and multiple chemical sensitivities that do not have access to holistic health care? Is this something that's been looked at in Health Links?
I mean, it's a good question. I can't. This is not this particular group of patients and their interactions with Health Links. I can't say one way or the other. I mean, if these individuals are using the system a lot and are identified through that process as complex, vulnerable people, then they just like anybody else in the province who has that same presentation of complexity and frequency of use of the system, they'd be included as part of a set of people getting a coordinated care plan. But as a group unto itself, I don't have any specific comment.
Okay, so maybe again it's another question. That's an example of a question that you could follow up directly, and the research priorities that are going forward. Another question is the role being actualized in complementary and alternative healthcare providers in addressing multimorbidity, particularly through Health Links. So what is the role that's being actualized in that domain?
I'm sorry, can you say that again? I didn't quite follow.
Yeah, okay, so a question from Kieran. What role is being actualized in using complementary or alternative healthcare providers in addressing multimorbidity, particularly through Health Links? So when you talked about the web of...
oh, yeah, okay, I understand the question now, and that's something... Sorry, somebody's calling in over the line. That's a question I don't know the answer to. Very interesting question, and that's one you'll have to follow up directly. I apologize for not having that information.
Okay, sorry, we're working you hard here, Michael. Another question, structures and processes such as Health Links, LINs, CCACs, et cetera, are intended to improve coordination and information flow. Would the ministry be prepared to measure the economic value added, so EVA, of these investments, such as the Health Links, and the benefits realized to maximize value for money?
I mean, the simple answer to that is absolutely. I mean, we have a hypothesis that I think is grounded in some pretty good literature around, what high-performing healthcare systems need to do and what integrated systems can produce, and we're certainly working hard to better understand and quantify that very notion. So, very good question.
So, work still to be done.
And if you happen to have any wonderful methods to do it, please send them forward.
Okay. So, we're running out of time, but I think two more questions, if you're okay on the line there. What would be some examples of barriers and facilitators that would enable the integration of care across the health sectors at the micro level? So interdisciplinary collaboration, communication, continuity of care, professional accountability.
Yeah, I mean, those, on this one, I'll give my answer, and just because I don't want to let Mike off the hook, I'll ask him to jump on as well. Those are all those elements that you mentioned are barriers and facilitators, all by themselves. So it's sort of depending on the perspective. I think about the work that O'Neill Bhattacharya did, or is doing rather, as part of the Bridges project. And Bridges project is all about, he got some research funding to look at people with, I think, at least 3 chronic conditions, and asked for proposals from Toronto-based individuals, care providers, so how they would work with at least 1 or 2 other organizations to better provide care for those individuals with 3 or more chronic conditions. So, and if that sounds familiar, it certainly is, and it was some of the early work that went into the genesis of the health links. And he talks about collaboration as something that happens following historical precedent. So if an organization has no historical precedent of collaborating with a certain sector or another kind of organization, you have to be very explicit about how that collaboration happens, and that can happen through lots of different ways: local leadership, different kinds of funding, different kinds of accountabilities, but it's something that needs to be guided, and because the culture of an organization will dominate its practice, and so if you're not explicit about how that collaboration needs to happen differently, whatever mechanism you choose to do it, it's not going to happen. So I think you look at leadership and collaboration as huge facilitators of this kind of integrated care, but then it becomes incumbent upon the senior leaders of the system and how to facilitate that leadership and that collaboration. And that can be again, facilitated by all sorts of other things like performance management, different kinds of solicitations of patient experience, looking at the cost and quality of care. I think to the question of from the audience around that extra value added, that's a key metric. So I think that's where I'd like Mike Wilson to jump in.
Sure, thanks, Michael. So sorry, you've been taking the brunt of the questions here. I think similarly, I would say that I think one of the biggest barriers would be just overcoming the entrenched way of doing things, that people are accustomed to certain ways of working in primary care and so on, and so overcoming those ways of practicing in the past is just very difficult. So I think I would have reiterated a lot of what Michael just said. There needs to be things put in place to either facilitate that leadership and collaboration, provide the right types of incentives, but then also I think it comes back to some of the themes that emerge from the dialogue about the bottom-up and person-centered approaches, and really trying to stick to that, but then also use monitoring and evaluation to demonstrate what works and when, so you can put some evidence behind this stuff and say, we're not just making it up that these are good, that we actually now have some evidence to back up that, these types of models are very helpful for patients and the types of things that they're interested in, and that can provide some helpful backup for moving forward with it.
Okay, well, thank you, Michael and Mike, and it's been a full hour and a half, and we are coming to, or a little bit over time, but I want to thank you for your presentations and sharing the work that's been done on this project with us. I want to invite everyone, as you log off, you will see a feedback poll pop up on your screens, and we ask that you take a few minutes to complete this poll. Your feedback helps us shape future sessions like this. And in terms of the future webinars, we have sent you a link to where you can find on the CIHR site the upcoming webinars. There will be one on May 6th related to pharmacare policy in Canada, and so you can find the details of that on our website. Again, thank you to the speakers. You can see here the contact information, a number of the questions that were asked. I think Michael Hilmer and Mike Wilson would both be happy to reply to some specific questions that you have in follow-up and engage in further dialogue. So again, thank you so much for participating today. We will be making a copy of today's presentation available to you, and it will show up such that you can download it. If you have any other questions or would like further information, you can contact myself or Howa Combian listed here on this slide. So thank you again. Have a wonderful afternoon, and we look forward to seeing you on the next webinar.